for joining us today. We're going to talk a lot more about getting to know the client. So there's a ton of different words that we could use. We could say clinical interview, we could say the intake process, we could say groundwork. There's a lot of different words, but they all boil down to pretty much the same thing, which is getting to know the client, what they're presenting with. And I'm graced here today by Dr. Eubanks and Dr. Brown, and we're going to chat again about this. So opening it up, talk to me about your style of whichever words you want to use, groundwork, intake, clinical interviewing, and what that looks like for you.
I think the interview process for me is very relational. I don't use forms. I don't like anything separating myself from the client. And I also understand, especially when you were a new clinician, there are so many questions. But after you do it like a gazillion times, you can pretty much run off the questions with people without actually kind of going through the form. And what you realize too in time in the beginning is if I forget a question, I'll just come back to it. I'll ask them next time or what have you. I think the sine qua non of what we do in the beginning is relationship building. And especially when you're looking at something like special populations or trauma or whatnot, building like safety and rapport and trust is just so critical. So I want the information, especially when you're dealing with a special populations and perhaps suicide or these days homicide may be involved. You definitely want to tackle those kind of questions early on. But I don't dip into those things until I have a relationship established or am establishing a relationship.
Yeah. One of the most problematic things I think of a lot of training programs these days, and it has been for years, is teaching the biopsychosocial and teaching that as being like a first session kind of thing, which is kind of the worst way to thrust a client into the therapeutic process. Tell me about your psychiatric history, your family psychiatry. Are you on medication right now? Have you ever thought of suicide? Have you ever attempted suicide? All these be hugely vulnerable in front of me right now, even though you don't know me. It's so put yourself in the client's seat is what I always say. And so having been a client many times through the years, I know that whenever I get to that point of I need to go see somebody, there's a lot going on in my life. And then there's the anticipation of that first appointment. And then when you're sitting in there for the first, couple of minutes or whatever, so you don't really know this person. And it's I've got this load of stuff back here in the closet and I'm just not ready to open the door fully yet. And I don't know that, so it really is, like Andy was saying, this relationship building process that has to be first and foremost. And really focusing on what brings them in and how they want to broach, the subject of why they're there. I mean, I'll ask them, so what brings you in, but how much is given is really up to the client and their comfort level. The more we push and prod to hear what we want to hear, they might have said something in their intake or in their phone call about, this big thing happening. Well, let's get to that big thing. Well, so what happened, but really it's got to be paced at a level, at a pace that's comfortable for the client always. Because once you break that rapport, I mean, you've broken the majority of potential for change with a client. In terms of formalities, just the way I've done it in my practice is that I will email all my intake packet to the client ahead of time. I request that they send it to me before the first appointment. I look through it. I mean, I use the cross-cutting measures from the DSM, depending on what's going on, back depression, back anxiety inventories. I've got my own intake, loads of questions, biopsychosocial kind of stuff. But that is not the focus of the session. If there's certain things that stood out on that were concerning, especially for the cross-cutting measure, I mean, I can see if there's, if they've had suicidal ideation or where they're at with a lot of aspects of their life that we do need to cover before they leave that first session. But if those aren't present and it's kind of a lot of general stuff going on in their life that they really need to be addressing, I really want to address what's first and foremost for the client, what's most relevant for them, first and foremost. That's what's, because it's almost like a job interview. You're trying to earn the trust and respect of this individual so that you can journey together from there forward. So anyway, let me stop there, but that's a part of kind of my take of all that.
We all sound really similar in the idea of making the relationship and the rapport and the connection still the front runner to all of it. Whereas I think that's in some ways oppositional to the training that is out there for helping professionals, where it's like the first session is you answer all of these questions and you get all of this information, and then you step into all of the other pieces. And yet I think it's interesting if you think about the idea that I always say, if you get all the answers to those questions that first session, you pretty much left the relationship in the dust. And you might have all your answers, they'll be surface answers. But the reality is you probably won't see that client again. They're not coming back to see you. So yay, you got all the answers, but you won't actually do anything with the client because they'll be gone. They didn't feel connected. They felt like, what's the point of this? There's nothing that really keeps them in that sense of hope and that sense of relationship. So I think that that's interesting to me. Like all of us seem to have that sense of what comes before the task. The relationship comes before the task. So you mentioned not doing it in the first session. I think that to me is like a myth in training for helping professionals. Is there's this belief that all of this information, the whole story or narrative of a person, will be obtained in 50 minutes. And I just think that's ridiculously impossible.
Well, yeah,
unfolds, right?
Yeah, exactly. And that makes me think of a couple of things. For one, a therapist that I saw once, the whole first session was intake. And I left. And so basically, okay, we'll look to start getting you help next week. When my whole anticipation was finally I get to go and talk to somebody. And it's like, oh, now I've got to wait a week because you sat here and like asked me 59 questions that have nothing to do with what's going on in my life right now. Second, what you said brought up for me in terms of diagnosis. One thing that I'm so surprised how much new therapists don't understand that the diagnoses change over time. And most of the time when they change, it's from the first session to third, fourth, fifth session, because you've spent time with that client and you've really been able to unfold their story of what's going on and really get a whole picture of what's happening with them. If you try and nail down, it sounds like, bipolar disorder going on here, and I'm going to dig into that. And I mean, you're going to be breaking rapport with the client, making them feel really uncomfortable, not addressing why they're there in the first place, and probably be wrong. So I've had, it's very, very common for diagnoses to change over time. And then, new things might develop as you kind of one thing becomes resolved. It kind of uncovers this other layer of perhaps trauma was beneath the initial depression that brought them in. And now we're kind of dealing with something else. You did great work because now it's like, okay, we're able to go deeper. So does that make sense? You'll follow that?
Yeah, no, I've had similar experiences, and I feel like, so much, and this is a different, soapbox altogether. So much is driven by insurance and their requirement for diagnoses in order to get reimbursed, which is why I don't take insurance anymore. One of the many reasons and whatnot, because it really does put you in more of a, you're a shop and you're trying to pump out a diagnosis in order to get paid. It's not about the therapeutic rapport. It's not about the relationship. And much like, what Rob was sharing, being in therapy, being on the other side of the couch, you realize how much of a vulnerability it is to share some of the answers to those questions. It's very much like emotionally undressing at times. And so you at least want dinner or breakfast or something ahead of time before you get into those kinds of questions. Hey, tell me about suicide in your family, that kind of thing. And while I can speak to that, and I've had suicide in my family and whatnot, I certainly could understand how that would be poignant with someone and actually break someone down just to kind of throw that out in from a very clinical standpoint without any kind of relationship buffer.
Yeah. When Dr. Eubanks is talking about this idea of like things change and we get more information and it evolves, it makes me think of something that you say, Andy, like, the onions and it peels away the layers, and what the client will come in with is often the symptoms and the consequences, but then as it unfolds and you get to see more of who they are, and you get more what I would consider those authentic answers, not just let me answer the question of what I feel comfortable in this moment as my first session with you, but like it becomes more real. There becomes more transparency and vulnerability. So the answer itself to those questions is not necessarily the same thing it was in that first session, because when the trust deepens, the actual story of the person deepens. So you get more of a real snapshot. And I think it's amazing that if we think of like a person that comes in who's going to, let's say, work out and change their body, we take a snapshot of them as they heal and as they reveal more of their actual self, and we actually get to see what we're working with. That snapshot changes completely, like from where we start. We can see that in a body, but it's so much different that we can't see it in emotion. So it makes it really hard for us to snapshot something when that's really all a diagnosis is. It's a snapshot, and it does change and it does move. And we're so focused on nailing it down when a lot of times that doesn't always necessarily have to do with the direction that we're going and the interventions we're going to use and the rapport we're going to develop and the curative elements. They don't always correlate with exactly that snapshot that we get on the very first session. So the idea that we work so hard for something that I think is not necessarily relevant in a way that gets us to the true end result is kind of comical in a way. It's very comical. And being on, I'll say being in the client role, I've actually left a session. I almost feel horrible in saying this, but I left a session because it was so focused on intake and questions. And as in my mind, I know supervisor, counselor, educator mind sitting in that role, I'm hearing question, question, close question, close question, close question, close question, question, question. And I finally stopped and said, I'm sorry, what approach are you working from? Because this is not working for me. Like literally, I had to stop and just be like, what is this? And I know that I put them on the spot and it was very uncomfortable. And I just said, I need to know that you have other skills in your toolkit, because right now the skills I'm seeing here don't make me feel confident that we're going in the right direction. And I hand selected, I looked, I searched, I made sure that we were going to have the ability to work. I'm a silver platter client. Here's what I want to work on. I just want awareness and reflection. I want to deepen on this. I'm just here to connect and explore. So all of this extra, let's just slow down. Like, let's slow. So I literally had to stop the session and it didn't go anywhere. I said, okay, I'm going to have to go. So I can echo how incredibly targeting almost it feels to have just question, let me get the information. When someone comes in saying, hey, I want a space. I'm looking for a space because I either need relief, I need help, I need a listening ear, I need comfort. That's what clients come in for.
Right. Yeah. So a couple of things that came up for me. One is, I don't want to gloss over the informed consent piece, but here's how it's tied in. Again, a lot of new therapists, the training is like, do you understand informed consent? That if you ever threat to harm yourself or someone else, that blah, 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 whatever, cops come handcuff you. It's just like this horror show of like, here's what's going to happen if you say the magic words, or, otherwise. Sending my intake information out, giving it to them, I'm assuming that they are responsible adults that read what they sign. And so they come in for that first session. And let me do a quick demonstration. Andy, be the client. Your answer is no. Okay. Andy, great to see you today. Got your informed consent and my intake packet back and everything. Just want to know real quick before we get started, did you have any questions on any of that, on the informed consent or any of the other information in there?
No, absolutely not.
100% of my clients answer no. And that's fine. What am I supposed to do? Dig into that? And well, I don't really trust that you're mature enough to have read what that's about. So let me make sure that you understand. They read it, they sent it to me, it was signed, we talked about that, and then now so what brings you in? I know you got a lot going on in your life. We talked for a few minutes on the phone. Let's dig into that. How can we start working towards getting you some help here? And that's as far as I go with it. But it's important to acknowledge in the first session, and it's important to have a really good informed consent intake packet written up that's aligned with our ethical codes and everything. But again, it's just can break that rapport and all the opportunity there to really start helping the client, having them feel helped. So what do y'all do with that?
Andy, you want to jump in? You look like you were thinking.
Yeah, I was just thinking about what he was saying, and it's one of those things. It's what I do parallels what Rob does, and I have my intake on my website, and I asked clients to go to my website for two different reasons. One, to get the information that they'll need to download and fill out to bring in, and also it gives information about me so they can begin to vet me a little bit more without having to ask me maybe some uncomfortable questions from the beginning. And then when they bring that in, very much like Rob, I, kind of explore any questions that they have with it. And much like Rob, I rarely get anyone asking any questions. I tend to skim or, kind of just basically scan the documents for the questions about suicide, homicide, those kinds of things. But I recognize that, I can read through the rest of this stuff between now and the next session. And I really just want to kind of connect with this person. And that really is my focus in the beginning.
I can't remember how long ago it was, but I had a chat with someone who said, I have gotten to the point where I don't really review the intake fully. I look for keywords. If the keywords are not there and I know there's no harm, and I've talked to them on the phone, we've already had that preliminary connection point, and I kind of know what the presenting problem is, I scan down to some really basics. I need to look to see what this is. And I spend the rest of the time just connecting with them and going over information about what brought them in and getting to know them, because what they're going to write on the intake form is going to be so much more surface than what it's going to be as we develop the relationship. And I think that to me has always stood out to me. It was, in the beginning, we think about getting all of these details and going back, like, tell me about your childhood and tell me about the relationship you had with your siblings, and like almost like we're going back and back and back and back, and we're trying to get all this information. We're trying to, tell me about your financial status, tell me about your medical history, your employment. It's like, okay, but the client's coming in because of this. And so I think there is something to say about putting the person first. Looking at these elements as the structure and framework, but they're not what we hang on. The meat is inside that framework and the structure and all of that. So kind of focusing on them. How long would you say that it would typically take you to feel like, if you had to fill out the intake, clinical interview, groundwork, paperwork, how many sessions would it take for you to actually fill that out as you're getting to know the client? Because I know we've talked about not putting it really into one session, but really understanding that it's going to evolve and develop.
Are you talking about like a biopsychosocial sort of thing? Yeah. Well, that's the thing with private practice is like, I don't have, beyond my intake information, which captures a lot of that, I don't do like a formal biopsychosocial anyway. And so much of the information is either captured on the intake or through our sessions, and then it's going to be captured in my case notes. So, I mean, I don't, I don't really do any more formal sorts of things beyond really that first session. So.
Yeah, usually within, I feel like I've got things pretty firmed up within 2 to 3 sessions, and that's if I'm dragging things out. And much like Rob, the only time I even kind of hint towards or lean towards any kind of biopsychosocial is if I'm dealing with someone who has an addiction and I'm trying to understand some of the aspects that kind of keep them involved in their addiction. And so it's more of like, what's your social group like, and, who's keeping you involved in this, and biologically, do you have, siblings or loved ones or parents that have had it, so I'm trying to get kind of this 360 view if I'm dealing with something like an addictions or whatever. But outside of that, just the general intake kind of information, usually within the first session or two, I have a, an understanding enough of the client in order to best understand them and the context of their issues.
Yeah.
And just real quick, as a marriage and family therapist, from my background and everything, genograms are really big with us, which capture the same thing, but in a different kind of format. And so I'll often, that'll be a part of my case notes, is that, and then that fills out over time as well too, which is kind of cool. So, and then a lot of, CES learners and stuff, are introduced to, y'all are introduce them to genograms.
Mm-hmm.
Right, and there, okay, I just can't remember when I taught over there, if that was a part of the process or not, but yeah.
Yeah, I'd say anytime the marriage and family piece is highlighted, I feel like genograms come out so quickly.
Yeah,
So quickly.
good tool.
Okay, so we're gonna wrap up with what's your one piece of advice that someone that's just learning how to do the groundwork with the client, what's your one piece of advice that you want to give them to take away?
Okay, I do want to address one. Can I go back and address something?
Yeah, go.
So the diagnosis thing, I was just thinking that somebody watching this might be like, well, my supervisor requires a diagnosis. So y'all are saying that like, that's not something, well, what do I do? What I've always told students is get really familiar with adjustment disorders and with the generalized anxiety disorder or the social, the anxiety and the depressive categories have much more non-specific. As a matter of fact, there's unspecified diagnoses that you can use that are just, I mean, if you stump your toe and cry, you probably meet criteria for one of those. So that's something you can do as almost a placeholder until, again, you spend more time with the client to be able to make a really reasonable, more grounded diagnosis, which it might not change from that initial thing, but more than likely it probably will. And then as they go from meeting criteria for, let's say, major depressive disorder, throughout your work with them, if you're doing all the things well and connecting with the client well, they will no longer meet criteria for major depressive disorder. That needs to be reflected in your notes as well too. It'll probably go down to maybe adjustment disorder or an unspecified disorder of some sort. But again, I understand that you all will need to have, diagnoses in there, but really get familiar with those, the many aspects of approaching that rather than just hearing something like, well, it's got to be PTSD and just going just thinking like it's got to be these big boxes of those require a lot of supervision too before, especially personality disorders. If you're going down that road, you better have lots of supervision for sure. Somebody backing you saying, okay, yeah, or no, we get these assessments, we really need to have them do first. And we probably need to pull in maybe psychiatric evaluations, before we let you, diagnose them with whatever personality disorder. So anyhow, okay, that's my 2 cents on it. So back to the conclusion.
Well, no, I was going to say the reality is that to me is ethically responsible in the way that a diagnosis stays with a person for a significant amount of time in their insurance records. that will stay in their medical record for a very long time, sometimes for life. And so if we are taking our due diligence and our time to really get to know them instead of forcing it in the first session, something incredibly large and heavy without really taking the time to get to know them and see the full picture, then we are doing them more of a service to take our time and to really make sure that we are accurate in what we're doing.
That's an entire another soapbox, for me, but with the diagnoses, I just feel like it's pseudoscience anymore, because they pretty much, people that putting together the current DSM are saying there's an interplay with, there's political interplay and there's interplay from the insurance companies and so on and so forth. And whenever you've muddied the waters like that, it's one of those things I know that we've got to do. It's a necessary evil to get paid or what have you. But do I look at this and really focus what I'm doing with a person on labeling them with something that really anymore is a pseudoscience? No, I do understand, and just like Dr. Eubanks was saying, it's one of those things that's taught. You have to do it, and for insurance, it's important and whatnot. But it's not the most important thing that we do in therapy. It's just not. And I think you should put the most important thing first, and that's the relationship building.
I love that. Yes, 1,000%. It's functioning in a dysfunctional system.
Yeah.
Okay. I feel like we just gave some advice, even though that was not the intent of where that started. But anything that you would throw out there as a piece of advice for someone who's learning groundwork and learning that first element of gathering information while developing relationship?
When you think about any time you're engaging in a new relationship, if you were to meet a person out at a restaurant, you're going to ask questions because you're driven by curiosity. And the curiosity is driven by your passion for the relationship. And that's, I think, something you do have a heart check. Where am I at with the relationship? Or, are you at that place where you have compassion fatigue and you're just kind of going through the motions or whatnot? Or do you really care about people and things to really kind of touch base on? Because if you do, the curiosity is going to drive this, and you're going to kind of get that information that's really critical for you to be able to help the person in front of you. And so for me, it's keep that curiosity and that caring, for the people in front of you, and let that drive your intake.
Love that.
I'm wondering if, I feel like we're probably unique voices. I was surprised to hear that you two kind of like, that we all have a similar process and we prioritize, similar things. I guess I wonder how unique we are, because having, going on 17 years now, teaching in master's programs for both mental health and marriage and family. I just find that first session is so driven into learners of it's got to be this formal thing. You have to establish yourself as a therapist. You have to have a diagnosis. You have to do the biopsychosocial. You have to talk about the informed consent. And I just, and then I've experienced that myself in therapy and being a client as well too. Not every time, but I guess my biggest piece of advice is to question, practices that are put forth in your programs, not in a bad, don't deny them, but just call into question, ask other therapists, ask your own therapist. Everybody should be a client at some point. Just really seeking outside voices like ours as well too, I think. People who've been doing this for a very long time and who've learned what works. That whole formality thing, I guess, comes with a sense of trust and confidence in your own abilities as well too, and that comes with time. But also trust and confidence in the client as well, and in their own individual strength and in the strength within the relationship. So.
I think my advice would be like the backside of yours, actually. They're very similar, but it would be prioritize the person over the task. No task is more important than the person that's sitting in front of you. And when they know they're the priority, all the other tasks, they actually resolve. Like it's amazing. If you do this one thing, everything else comes into place where it's meant to be. But when the task becomes the priority, everything else will fail. When the person is the priority, all tasks will resolve. And so if that can just remain the focus, I think the information comes, the transparency comes, the vulnerability comes, the information that you needed comes when they're the actual focus. So
Beautifully
okay.
stated. Yeah.
All right, you guys, wonderful conversation. Thank you so much.
Thank you.